bright futures. So from 0 to 1 year of age, there's 6 visits that are considered. From 1 to 2, you have 3 visits, and from 2 to 3, you have 2 visits. Now, visits, of course, vary. And by that, what I mean is that, for example, I can schedule visits at 1 month, 2 months, 4 months, 6 months, and 9 months. But you sometimes will have patients who either what we call no-shows or for various reasons cancel out. And so then you're trying to make up some of those visits. They coincide with immunizations, and so that's what also throws you off, because if a patient misses the visit, then they're already behind on some of the immunizations, and so you're playing catch-up. Here are the components of the Epsdt Bright Futures test. The first thing involves the history, and history can be very extensive. For example, you're asking, it's supposed to be an interval history. What has changed since you saw the patient last? You know, if the child is very healthy, if they don't have any problems, this can be very quick, and there may not be a large component to any of the recent changes. But I can tell you that a lot of times when a kid comes in for their Epsdt, they are sick to begin with. So it's not uncommon for me to have a patient coming in for their Epsdt checkup, and they're coming in and they've got 104 fever for the last 3 days, and they've got some acute illness. And at that point, you're having to address that. You have to get a history on that, etc. Another thing that can really extend these histories is we have a lot of kids who have chronic illnesses and multiple problems. Again, an example would be for a patient who has asthma. So the child with asthma comes into my office. I'm going to be asking them about, you know, how are they doing with their asthma? What's been going on? And you can imagine that that can become very extensive, especially when you're supposed to be reviewing medications, etc. Another thing that we need to review with these kids with chronic problems is when was the last time, especially if they have referrals to specialists, when's the last time they saw the specialist? And then we have to go back and see if we can find out what the notes were. What did the specialist tell us about what's been going on? What have been their recommendations? So that's just the interval history part of the history. We also do a review of systems where you ask about any various symptoms that they may have concerning things like, okay, the respiratory system, the urinary system, etc. So you ask questions like that. You also look at any changes in the family's health history. Has mom now developed, for example, some chronic illness? Does she have lupus now, or does dad have some problem? Grandparents. You go over medications, so you're supposed to find out what medications are on. And this can be very, very interesting because even though we ask the patients, and it's when we make the appointment, we tell them to make sure they bring their immunization and their records and their medications, it's not uncommon for them to not bring medications. It's not uncommon for them to not remember what medicines they're on. And remember, many times they're getting medications from other providers, not from us, especially if they have, if they're going for multiple problems to specialists. And I may not get the information from the specialist right away either. So it may be that, you know, they don't send me a letter for 2, 3, 4 months. And so trying to sort out just what medications are on, you know, that in itself can be very difficult. And then finally, we ask if there are any changes in the social history. So history is a huge component to these things, and it's very important, especially when we're trying to coordinate care for a patient. The next part is the physical exam, and in many ways, that's probably the most straightforward thing that we can do. A couple of screening things that we do on the physical exam, besides just the standard part, we always want to make sure that at 3 years of age and older, they have blood pressure screened, and we also want to make sure we do a screening for dental. By that, I mean we look at the teeth, and if we find any problems, then we try to refer them on. So that's the component of the physical examination. Then we have the screening part, and this is probably where most of you have run into all the problems with not having it completed. Because the screening, and I'm going to go into this a little more extensively, can really be difficult for providers. We provide immunizations, you're supposed to be. Now, this also may be difficult because not all providers give immunizations in their office. The major response is, well, why not? And quite frankly, there's a number of reasons why not. One is getting immunizations to the office is not easy. It's a very expensive procedure. You may or may not even break even giving immunizations in the office. And there's a lot of work to make sure that you are maintaining what they call the proper cold chain on the immunization. So in other words, that you're not giving somebody immunizations that are going to be ineffective or have not been properly stored. And so there's a lot of work in immunizations. And so many providers may not give the immunizations in their office, but may send patients to either a health department or someplace else for the immunizations. The D part is the diagnosis, and there can be a couple of different things. First off, I told you, there may be an acute illness that's involved, so you're making that diagnosis. You also have to try to at least, remember, we're doing the medical records, kind of the main medical record for these patients. It's sometimes really hard to sort out what the other specialists or what specialists have diagnosed. Many times the parent doesn't really understand what they've been told by the specialist, and so you're trying to sort some of this out. And indeed, the other thing is you're looking at any kind of referral letters that you may have gotten, and again, those may be delayed. So, but at least trying to document what diagnoses this child has, if any, is an important part of this. And then the last part is treatment. And the treatment may involve things like referrals. If you find an acute problem that you feel needs a specialist to look at, it may be a referral for developmental services. It may be that you're prescribing medications now for some of these acute problems. It may be that you're refilling medications because they initially got the medication from the specialist, but now they can't, they're calling down there, they can't get the medication. I'm always thinking of asthma in these cases. So you're refilling their medication. You may be ordering some diagnostic labs and x-rays, which are not the screening labs, but are involved with any acute illness. Some of us are starting to do fluoride varnish applications. We would like to see more providers do that. And finally, the last part is education and anticipatory guidance. And this again can take up a lot of your time, and it should, because you're talking to these parents about various issues on preventative care, whether it be diet, whether it be behavior issues, etc. So that's the component of an EPSDT. And as you can see, it's a very, very extensive workup, or at least, if you follow all the guidelines, it is. So what are the problems that a provider has in doing this? The first thing is that most of us in primary care, when we're doing checkups, we're doing probably somewhere around a 15-20 minute time frame to do a checkup. That in many instances may be enough time, but in a lot of instances it's not going to be enough, especially if you have to do all these different components. And on top of that, you're looking at some other issues or trying to coordinate care for chronic illnesses. In the past, quite frankly, payment for Medicaid services like EPSDTs has been very poor. In many cases, it would only barely cover overhead. If it doesn't cover overhead, in essence, you're paying to see those patients. And so providers in the past have been a little hesitant about doing EPSDTs or even seeing Medicaid patients. Recently, with the Affordable Care Act, payments have increased, but they haven't increased as much as you might guess. Currently, I think I get something like about 70% of what I would get paid for seeing a patient with insurance to do the same exam. The other problems there is just what I said. There's a vast array of problems that the patient may present with, and it may be that it's the acute illness. And when it's an acute illness going on, you have to address that. That parent is there for you to take care of that. And so when you're spending your time working on this acute illness, you may forget, or it may be that for whatever reason, not saying that they should, but the provider may concentrate on that acute illness. You have chronic illnesses, and that can be really difficult sometimes to sort out. If I have patients who are seeing 3 and 4 specialists, and that's not uncommon, I'm trying to make sure that they're going to their appointments. I'm trying to make sure that they're following the recommendations. And so a lot of this time that I have in this 15 minutes or 20 minutes may be spent doing those type of things to make sure that that patient is getting cared for the chronic illnesses. So I guess what I'm saying in a way is that we're having to prioritize our time. And so what we may, when we're as a provider, I may say, wow, it's really more important here. The most important thing that I do is take care of this child's asthma, rather than maybe spend a lot of time talking about how they should be reading to their child every day. Now, don't get me wrong. Reading to your kid every day is an extremely important thing to do, but I'm forced, because of time crunch, to maybe make some type of decision on which I'm going to talk about and how much I'm going to talk about. Finally, another issue has to do with the ability of providers to provide services on site. I told you a lot of providers, or not a lot, but some providers may not give immunizations on site. So what they then have to do is send the patient to the health department or some other facility to get the immunization. And you can imagine the difficulty that that parent has. It may be that they have a job where they can't take a lot of time off to do this. It may be that they have difficulty with transportation. So the result is that they tend to maybe fall behind when you can't get that service on site. And the same is true with labs. I don't have laboratory services here in my building. We've looked at it on numerous occasions, but to get the proper machines to run the labs and then to sit there and maintain your certification is really cost prohibitive for us. So when I do the lead screening, for example, I have to hand them a sheet of paper and tell them where to go to get that done. That's relying on them, the patients now, to go and get that. And again, can they take time off of work to do it? Maybe not, maybe. Do they have transportation to get it done? Difficult. So these are all the number of problems that we see as providers. I told you I'd kind of go over screening because I think this probably is where we run into a lot of the problems with not having completed EPSDT. And I'm going to look at the 4 areas: hearing and vision, iron deficiency, development, and lead screening. I left lead for last because that's the one that just, I can guarantee you, drives providers crazy. But first off, hearing and vision. You do hearing and vision screening. Technically, you do that from the first day you see the child. But when we start doing more of a specific testing for it, it's usually started at age 3, and it's then yearly thereafter in your probably your age groups. One of the things that I think probably the most common hearing screening is going to be an audiogram. It is a machine that we use. We use it here in the office. We have audiograms. We have them connected to our computers. It is strictly a screening tool. You do run into some problems, which I'll mention in just a second, but that's what we use for hearing screening. We also, as far as vision screening, we just use a Snellen chart. There are some offices that will have very fancy type of vision screening machines that they use, but truly, if you look at the guidelines, a Snellen chart should do just fine. The problems we have with this screening is just really one that the patients may not comprehend very well what we're asking them to do. We generally tend to have pretty good luck with the Snellen. Our nurses are pretty good at that, and we use various forms of it that can go down to pretty young ages. But we do have struggle, especially for the 3-year-olds, in getting audiograms where we feel like they're doing it correctly. So a lot of times, we may attempt it, and when we say we've attempted it, that is actually fulfilling the component. But I'm sure that when you guys get the sheet that just says it wasn't done, and so you may have thought that they didn't even attempt it, but they may have. The provider may have attempted it. Iron deficiency testing mainly is done at a year of age. The standard tests that they use for this, hemoglobin, hematocrit, maybe even a CBC, really, these are only testing for anemia. And so one of the problems with iron deficiency is that that the tests that really tell you about iron deficiency, which are much better for that, aren't covered by Medicaid for this. First off, why do we even test for iron deficiency? We test for iron deficiency because data has pretty much shown us that it can affect the development and the cognitive abilities of children. And 1 year of age seems to be the most significant time frame to check for this. As I said, when we're doing the test, when you're doing a hemoglobin check or you're doing a CBC, you're really just looking at anemia, although the CBC will look at maybe a little bit more, but that's one of the last things that you'll see in iron deficiency. The other tests that seem to work much better or give you a better example of whether that child is iron deficient or not is the serum ferritin, and that's really not covered for screening. So when we do these tests, again, in many ways we're missing out on these kids that maybe are iron deficient, but they're not anemic. So at best, this is kind of a poor measure of it, but it's basically what we're required to do. Again, problems are that most of us, or many of us, may not have on-site labs, so when we order this and give the sheet to the parents, whether they go and get it or not varies. If they don't have it done within 2 weeks, we send a backup letter to them saying, please go and get your lab done. There may be some parental resistance in this because, again, this is blood, drawing blood from the child. Some parents aren't real keen on this. And remember, a lot of times I'm telling them, okay, well, we need to do this because this can affect your child's development. Well, I've done a developmental screening on the child earlier, and I told them that maybe the child is growing and developing fine. And so, they're thinking this. They're going, okay, well, he's doing fine now. Why would I think that this, his development is affected? And so they may not be, and this is not just Medicaid patients. This is all our patients. So they may not be as ready to go and get this lab test done. And again, once we try to do a follow-up to say you didn't get it done, please go get it done. But short of that, they may choose not to. Development testing is an area that I think providers really have failed at, quite frankly. We really need to improve on this. Currently, there are a number of standardized tools that providers can use, and actually they're very quick, and they give a much better indication of a developmental issue or problem than the standard, what a lot of providers were taught, where when you just ask questions about the development. And I think this has been shown in numerous studies. What the requirements are is that they should have developmental surveillance done at least at every visit. They should have screening done at least 19 and 15 months, and they should have MCHATs done at 18 and 24 months. And that's kind of what we've been doing. The surveillance that we do, we use the PEDS, P-E-D-S, and we do that at every visit. In addition, we do ASQs at 9 and 15 months, and we do the MCHATs at 18 and 24 months. And if there's any question on the PEDS, or if there's any question that we have when we're talking with the parents, we'll go ahead and do an ASQ at other times too. So we can do ASQs at basically any visit they have. There has been a real problem with getting providers to do these and to use these. And part of it, I think, stems with what they were trained. They were trained to maybe ask questions instead of using questionnaires like this. I think that the Kansas chapter of the American Academy of Pediatrics, which is who I'm representing, we've worked pretty hard at trying to get providers to do this. We've done a number of seminars and where we go out to the providers' offices, show them how to use these things, explain to them why they're maybe important, why they are important to do. And so we're working on that. But this, I think, is definitely an area where we really need to get providers to start doing better developmental screening. The question always comes up, though, too, is what do you do if you do get a positive screen? Each area you need to know who can do your full developmental testing and who you're going to refer patients to and how you're going to get services. And that should be a provider's responsibility. Our KAAP has tried to help out a little bit with that too. We have an online resource guide for the state that hopefully will help sometimes with providers in seeing who is out there for some of their screening, or not for screening, for testing and who they can refer to. The last thing I'm going to talk about is the lead. This is really, I don't know if I want to say it's controversial. It's very confusing. First off, let me just say that what's not confusing is that lead can certainly cause problems with development abilities and cognitive abilities. What has been a problem with lead testing for providers is that we get mixed messages a little bit on this. Initially, I don't know if many of you could remember this, but an acceptable lead level used to be below 10. Then when studies started showing that even in lower levels that it can have an effect, then of course then people started saying, well, wait, 10 is too high. The trouble is that the studies show that any lead could potentially cause problems. So if any lead could potentially cause problems, then what the new guidelines say is that if it's 5 or above, then we start doing something. Well, for a provider, your first question is, okay, if any lead level is a problem, why are we allowing anything less than 5? I mean, that makes no sense to many of us. How did the number 5 get picked? The number 5 got picked by the advisory committee to HHS because it is 5 or above is above the 97th percentile of blood lead levels in this country. So it's not so much based on, is that a safe level? It's just based on, well, that's above the 97th percentile. Okay, that's what we're making a decision on. The test results may vary. This is an interesting thing, too. And this is what makes it difficult, is a blood lead level can be plus minus 2. So if I have a 5, it could be 7, or it could be 3. And so if it's 3, well, you're supposed to say that's okay. But if it's 7, well, we need to do something. The results then, because of that variation, if you have a kid who has a level as 5 or above, what you do is you don't do anything until you repeat it, which is in a month or 3 months later. So you get a level. It's not, you may or may not be accurate. You repeat it in 3 months or 1 month, whichever. And then if it's still elevated, then that's what kicks in the process. Now, so I get a lead level on a kid, and it's 6. So I try to contact the parent. I finally get hold of him maybe, and we say, you know, the lead level is a little elevated. We just need to repeat it in a month or whatever. And so now it's a process of trying to get that patient into the lab to get that test done. And to a parent who may feel like the child is just doing completely fine and is normal, and indeed the child very much is, probably. So what do we do treatment-wise? If the test is 5 or above, what do? And it's confirmed. Well, you call the health department, and the health department goes out, hopefully if they have the facilities to do this or they have the funds to do this, and looks at the environment because that's most likely where the lead has come from. So they do environmental management. Do they have, I mean, and that's a big problem, I think, for some of the health departments because they may not have as good a funding as we would like. But that's all you do. There's no medicine that you give these kids. The only time you do any chelation therapy is if the blood lead level is over 40. So it's kind of and by the way, if you do have a blood lead level, there's no way that's elevated. If that has caused any effect, you can't reverse that effect. So there's no treatment that's going to reverse the effect that you've seen. So what do? Probably the best way to manage these things would be by what's called primary prevention. But even the CDC says we do not at this time have enough money to do primary prevention in this country. So what we're doing is we're kind of waiting till after the fact, and then we're trying to make some type of an adjustment based on that. And then lastly, this is I think probably one of the bigger problems with providers is the prevalence of lead levels. What you find out is that elevated And I've involved with, or have very good friends at KU Medical Center, and they did a study recently. They looked at the blood lead levels of, I think it was 1,500 kids that they had. Every child they had who they did a blood lead level on, and they have about 60% Medicaid. From January to September, and I think it was in 2013. You know the number of confirmed blood lead levels over 5 that they had? It was 0. In my practice, I don't know that I've had a confirmed one over 5 for a number of years. And so what happens is that what we're doing is we're doing a blood test that we're not seeing any elevated levels, actually. And so what you find out is that then I think, and I'm not saying this is right, but I'm saying what you're going to see is I think providers are going to just tend to kind of say, oh, well, okay, they didn't get the blood lead level this time. So what? Who cares? I'm not saying that's the right way to do it, and I'm not saying they should, but I'm just saying that's human nature, and that's what you're seeing. So, that's a quick overview of this. I'm certainly open for questions. I just want to make a couple of other comments about it, is that when you're looking at when these kids don't have all the screening done, first off, just know that it may not be because they weren't, it wasn't attempted, or that the provider didn't try to get the screening done. The second thing is always be careful on how you approach this. One of the things that I always find out from other providers, we're bad at this, is we kind of sometimes think out loud, or we make a comment. For example, I had a patient of mine who went down and saw one of the pulmonary doctors at Children's, and she came back to see me, and she said, the pulmonary doctors there say you need to send my child to the gastroenterologist. And I kind of went, oh, okay. And I went and looked at what the referral letter said, and the referral letter didn't say that. What it said is you need to go back to your primary care doctor and discuss about possible referrals. It may be a GEI doctor, it may be someone else. So my point being is that you got to kind of watch what you say when you're going telling people they need to get something done or they need to get done. Just remember that parents, and this happens to me all the time, they may not exactly understand what I'm saying, and it's true for physicians probably more than anybody else. We don't make ourselves clear, and communication's two ways. They have to interpret it right, but we have to say it right. Mm-hmm. So when we're talking amongst each other, I think that's probably a real key. We need to talk probably directly to each other and not through the parents. Mm-hmm. I hope that kind of gave you guys a little bit of an overview of some of the issues that primary providers have. I think we need to do a much better job on our EPSDTs, but I do think that it is sometimes hard to get all these various components are part of it. And so I open up to any questions people might have.
Does anybody have any questions, or maybe even insights as to something that you learned? *6 to unmute your phone.
I have a question. I'm Stephanie Lindsay here in Topeka, Kansas. And can you hear me?
Yes.
Yeah.
Okay. We do a lot of these same screenings here, and we do vision and hearing screens. We also do some of the lead and hemoglobin, weight dose hemoglobin. Would it be beneficial to the physicians to collaborate a little bit more and share our information?
Oh, gosh, yes. Here's what happens, too, a lot of times. Again, and parents, I'm not putting them down for this, but sometimes they'll tell me something like, you know what, they had that test done at the WIC office, and I don't have any report of that. And I go, okay, well, I don't want to put the child through getting another set of labs. But what I may find out is either it was one of the other kids that got the lab, and they just, for forgot, or or maybe they only got one component of the lab, and so they got the hemoglobin, but maybe they didn't get the lead, or vice versa, and so or we don't know what the results are. So you bet that would be really great, and I'm sure that's probably true in most areas. Another thing is, what happens if somebody has a hearing and vision screening done through some other group? Not necessarily for our Head Start kids, but certainly for maybe for our Head Start kids, but I know certainly in our school age kids, they get hearing and vision done yearly. And do we need to put them through it again? Maybe not. Probably not, because they're going to do the same screening that I'm doing. But I just don't get the results of any of that. Right. And it would be sure nice if I could.
I'm curious, Dr. Cooley, if there's any opportunity now with electronic medical records that for possibly enhancing sharing results more effectively, what that might take to take advantage of that.
I'm gonna say no, and I'll tell you why I say no. Do you know how many electronic health records are out there right now? About 4,000.
Different systems.
Different systems that do not talk to each other.
Uh-huh.
There may be ways eventually through KHAN, some of these various networks that are being developed statewide for transfer of records. But oh my gosh, I can't get the labs from the hospitals here in my town into my electronic health records. I have to get hard copies of them, and then I put those into my electronic health records. So it makes perfect sense that you should be able to, but right now we're not at that point. That's the same true with medications. That's why that's why a provider goes through so much struggle with medications. The docs down in Kansas City at Children's or KU, they may change medicines or do that. They enter it into their systems, but I get a hard copy, and usually it's me. I have to now go in and change all the medicines by hand because they don't talk to each other. So
wow. That's helpful. Thank you.
And I'm in Northwest Kansas.
Uh-huh.
And I do on an average probably 150 leads for our program every year.
Uh-huh.
We cover 12 counties, so I deal with a lot of different docs and a lot of different health departments. Unfortunately, part of our WIC program does not do any kind of lead, so that is not an option for us. One of the things that we do is when we do a lead is I send a copy of my results to the medical provider so that it can be put in their file at their clinic, because like you said, it could be there's other things that are affected, not just the lead. So we feel like it needs to be assessed when the student is being seen by their medical provider. But one of my questions is, if you really feel like, and if the American Academy of Pediatrics really feels like the lead is not a valid test, then why isn't it taken off the EPSDT since no one wants to do it?
I probably shouldn't. I've maybe made this kind of wrong. I think we sort of find two different types of groups. I think you have those that are kind of going, gosh, the leads don't help us a lot. And then you have people where lead levels are very high in their areas, and they have good reason to say we need to keep doing lead levels. I don't think that it's wrong to do lead levels. I guess I shouldn't say that. I think that it's not the best way to do things, but I think we should be doing them. But I think what you have to realize is that there needs to be a better way to do it, and primary prevention is a better way to do this. But I can tell you right now, society isn't going to pay for that. I don't know what to tell you except that, as far as I'm concerned, I still try to do them. I must admit, if my patients don't get it done and I send the card and it says, please get it done, and they don't get it done, I don't keep probably nagging on them. Maybe I should. But I think that's what you're saying. And I don't want to give the impression that all pediatricians in the AAP are against lead testing. I just want to give the impression that, or just kind of make it clear that it is a little bit confusing for a provider, and you are going to find providers, especially if they don't have many lead levels in their area, who are going to say, why are we doing this? But I don't think, I don't think that these main groups are at that point where they're saying, oh, this isn't this isn't a valid test. There are problems with it, don't get me wrong, but, I think that's what you're seeing. And so, unfortunately, because I'm in an area where I was actually interested to see if you were going to tell me that you have quite a few lead that are elevated, because there's supposed to be in areas in Kansas that do.
Yeah, we do. We had, I would say we average at the most maybe 5 a year, but you got to remember I'm in 12 counties.
Right.
And a lot of that comes from our oil workers, unfortunately.
Right.
Yeah.
Right. Mm-hmm. And so, so if you get them, it makes sense. It's just that when you're in areas, it would be better if somehow, we could, here's, I guess, what I would recommend if I was, king of the world. I would say, let's find out those areas in our state, for example, where we have those high lead levels, and then let's concentrate doing primary prevention in those areas. That, to me, makes sense.
Okay. Maybe we have time for a couple more questions. I got one that came through on the webinar. It says, is the Epsdt requirement for a hemoglobin or a CBC?
We do CBCs, and the reason I do a CBC is it costs the same as the hemoglobin, and it may be that they've kicked it up now, and I've been doing CBCs forever, so I don't know but it used to be that hemoglobins were okay. The reason I do the CBC is you can get, for the same cost of the hemoglobin, and it will be covered, you can get not only the hemoglobin hematocrit, but you also get what they call the indices, and you get the RDW, and those will give you a little better idea. The hemoglobin, for example, may be fine, but if you have some indices that show that they're low and your RDW is a little elevated, then it may indicate that there's iron deficiency.
Okay. Thank you. And then
I think it's a better test than just a straight HH.
Okay. And then Stephanie Montgomery, did you have a question?
No, this is Sue, Eric. We're down in southeast Kansas, and we cover 12 counties also. And we have found a lead questionnaire that the doctors have been doing, the providers down here, and then they will decide whether the child needs the lead testing. And so what I did earlier this year before school was dismissed is I went around to every one of our providers in the 12 counties and gave them a copy of the performance standards for Head Start and what they require. And our lead testing has been a little bit better. We have 852 children enrolled in our Head Start between home base and center base. And Montgomery County, Labette County, and Cherokee County are our areas of high lead. I've had them as high as 27. And we just work with the parents and help them move or whatever that we need to do. We have had the health departments involved, and also Children's Mercy has come down. Them are just some resources that, but I was wondering on this questionnaire, has the providers across the state ever thought about doing the questionnaire?
It's a good question. We use the questionnaire in our office. I still do try to do it I try to do leads on everybody at 1 and 2, and the reason I try to do it on everybody is if I just try to do it on my Epsdt kids, I forget. If you try to do the same thing on everybody. But we use the questionnaire. It's very interesting because if you look at the results, there are some studies that show that the questionnaire works pretty well in screening, but there are others that don't give quite that good a result. And so I'm not sure how effective it is in a practice. We use it. It makes me feel better, I guess, if they don't have any risk factors and they didn't get the lead level, then I probably feel a little better, I guess. But truly, the funny thing about lead is, for example, you may get lead in a toy from China, and so the kid is, chewing on that. That's not maybe one of the questionnaires, at least in some of the ones I've seen. So you can get lead from various places that a questionnaire may not cover.
Yeah, that's completely understandable. I know ours is mostly probably from the mining down here, the past coal mining and the present coal mining that goes on. And on the others, like I said, I made rounds to all our providers. But we have a partnership agreement with all of our county health departments and the community health of Southeast Kansas. And they try and make sure they do hemoglobin and lead, hearing, and vision on all Head Start children.
Yeah, I think that's great. And again, if as a provider, if somebody sends me a thing and says, we've done the lead test on them, and here's the results, boy, that's great as far as I'm concerned. That has saved me a lot. But it does, but most of us, I think, are still going to be sending kids to various labs to get the labs done. And again, I'm not blaming people. It's just hard to get that, whenever you're providing a service and out somewhere else, it's hard. You're going to have some missed opportunities, and that's what we see. I see that at least in my practice a lot.
Okay. And Stephanie Lindsay, did you have a question?
No, I don't.
No.
Mine was already answered. Thank you.
Okay. All right. And then Leticia, did you have a question?
No, I don't.
Okay. I just saw a hand raised, so that's why I'm checking. Okay.
I do have a question. I'm Beth Hazen, and I'm in Dodge City at Early Head Start. We always do our MCHATs at 18 months, but your notation said you need to do them 18 months and 24. Is this correct? You have to repeat it?
That's correct. You should do it 2 times. It can't. You can't do it under 18 because it's not been shown that it is effective under 18 months of age. So we do it at 18 and 2 years, and I think that's pretty much the standard way of what the recommendations are. I'm not sure the EPSDT requires you to do that, but we feel like that's probably when you ought to be doing it.
Now, another question, like if we have a child who comes into our program at 30 months, and they're beyond the 18-month one, we should still do a MCHAT.
Yeah. I'm sorry. Those are just when you do the screening. But yeah, standard screenings. But yeah, you can do it anytime. It's like an ASQ. I may only do it at standard at 9 and 15 months. But if I got a kid coming in at 12 months and I'm going, wow, I'm not sure on this, I'll go ahead and do it at 12 months too. Or I'll go ahead and do an ASQ, for example, at 4 years of age. So yeah, you can certainly do that at older ages too.
It's probably best practice to go ahead and at least get it once while they're in your program then.
Yeah, I think so.
Okay, thanks.
Well, everybody, we are about 3 minutes to the end of our webinar, and I just want to make sure that we're respectful of people's time. So, if Dr. Cooley has time to stay on and answer questions, that would be fine. And if people wanted to stay on, I think Steve Shuman though is going to stay on, and he'll present a couple of resources. But if you cannot stay on the webinar, we will make sure to send out his slides and those resources afterwards by email. But I did want to mention that we have a couple future meeting dates or webinars. So December 8th and then March 9th will be 2 webinars, and we are looking at topics of maybe doing vision screenings and your role in enrollment. And then May 11th is another one that we're going to have. But then also on April 9th, we will have our face-to-face health managers networking session at our membership meeting in Salina. So I'll make sure to include those in the emails as well. So were there any other questions for Dr. Cooley? Okay. If not, Dr. Cooley, you're welcome to stay on and listen to Steve's presentation if you'd like, but I know you're busy, and if you need to sign off, then we completely understand. But thank you so much for taking your time to present to us today. I know I learned a few things, so this is really helpful. I appreciate it. Thank you.
You bet. I have to go. I have patients
Yeah.
waiting for me now. So I'll go ahead and you'll take over, and I'll just close out here.
I will. That sounds great. Thank you.
Thank you.
All right. So, Steve, I think I'm giving you control.
Hey, thank you. And I'm going to ask you to tell me when you can see my screen.
I can see it.
right?
Yeah.
Okay. And if I can move that little thing. Okay. Okay. Thank you, Eric and Peggy, and especially thank you to Dr. Cooley and anyone else who's staying on. I'm Steve Shuman. I'm with the National Center on Health, and it's been a pleasure working with the Kansas Head Start Association to get these calls up and running for this year. It feels like a real strengthening of a strong group of health service managers across the state of Kansas. I don't know if you can see that little thing. I was trying to, sorry. There we go. Okay. So very quickly, the National Center on Health has a number of resources, and I know that we're already at the top of the hour and sort of out of time, so I'm going to go through this relatively quickly and then hope that the printed document that you get as a handout is helpful and people will follow up with questions. The National Center on Health has a number of areas of emphasis. I am sure that you are familiar with all or most of these issues, whether they are your priority issues or not. It's obviously different from program to program and from year to year. But these are the issues that the National Center on Health has, the Office of Head Start has asked the National Center on Health to focus on. We are well aware of the emphasis on school readiness, and what we are hoping is that each of you have an opportunity in your programs to emphasize the connection between school readiness and health. The National Center on Health resources live, like all Head Start resources, on ECLKC. If you haven't gone to the National Center on Health pages, we strongly recommend that you go there. You'll find these 12 boxes when you select under the Training and Technical Assistance area, Health, and each of these boxes enters a whole long list of multiple resources, webinars, printed materials, and updates. We started our work we are entering our 4th year next week, so 3 years ago, and we started by addressing the issues on school readiness. These are both fact sheets that live in both the school readiness part of the National Center, ECLKC, as well as at the National Center. One of our newest materials also connects health and school readiness, and this is an interactive tool called Making the Link, and it was just released a few months ago. One of the tools that I'm proudest of is finally linking the Caring for Our Children, the National Health and Safety Performance Standards, which are not regulations but science-based recommendations, to the Head Start Performance Standards. And Compliance with Care is an interactive tool linking the required Head Start standards with these recommendations. It's an electronic tool dealing with just about every health topic you can imagine for the age group that we care for in early Head Start and Head Start. And you can get printed copies, or you can download a PDF or access the electronic copy at nrckids.org. What we have done is link this electronic version with the Head Start Performance Standards. So you'll see when you're on the NCH page in ECLKC, these headers that all sort of fit with the Head Start Performance Standards, and then they open up, the accordion opens up. These are the areas that you're probably very familiar with, and then list on the left-hand side the Head Start standard, and on the right-hand side the Caring for Our Children standards, and they're all hyperlinked so that you can go in, pull up the standard, go in, and pull up the recommendation. The recommendations have, the rationales, citations, additional resources, samples. It's a whole lot richer resource than what the Head Start requirements we can have. We have newsletters that are issued out every month, and those are on the website, as well as fact sheets that are written for staff. We have webinars. We have fact sheets that can be given to families, and these are now, they're now available in Spanish as well. We, along with our partners at the American Academy of Pediatrics, have access to this online well-visit planning tool, which fits with what Dr. Cooley was saying today about EPSDT, and really empowers the parent to be able to make the most of those well-child visits. Of course, oral health continues to be a major issue in our population, and our oral health partners at Georgetown University National Maternal and Child Oral Health Resource Center have developed forms, which most of you should have received in the mail, as well as provider letters that you can use. And they also have a very specific newsletter just on oral health that you can get off of the website. Brochures for families in Spanish and English, and a tool to identify which Head Start oral health curricula, will work best for you all, for each of your programs. There are tip sheets to share with community partners. We heard several of you have done some outreach around screening requirements in Head Start with your local providers. This does the same kind of thing with oral health providers. Some of our newest materials are around helping families achieve and maintain a healthy weight. We have flip charts, which have talking points on one side for the staff, and key messages and photographs for families on the other side, called Growing Healthy. There are customizable tear sheets and reminder postcards, all linked with the 5210 messages around nutrition and physical activity. Mental health continues to be a major concern, and we work again with another part of Georgetown University, the Center for Child and Human Development, and all of the materials they have created for staff and for Head Start mental health consultants, as well as families. A good deal of these materials are in English and Spanish as well. They're all downloadable and free, including these multicolored posters that can be printed and put up or shared. And some of their newer resources are about talking about depression, finding a mental health consultant, facilitating referrals, all to support mental health services in your program. Our newest materials are addressing toxic stress and will be available very soon. We're just ending, as I said, our third project year, and these are in the process of getting posted on ECLKC as we speak. Also coming down the pike is a new health manager's orientation guide with online training modules. These have been tested all this past year and are getting ready to get posted on ECLKC. There is currently an orientation guide. This updates that considerably. We refer to the guide as the HMOG, and you can see how it links with both the priority areas and performance standards. And finally, I just wanted to mention that these calls are a part of another initiative the National Center on Health promotes, which is networking. So opportunities for you all to speak with each other, share, ask questions, and learn from each other. And the work that I've been doing with Eric and Peggy at the association, with Diane as a representative or voice for some of you, has been really helpful in making this connection between what the National Center on Health can do and your work. I'm going to skip over these next few slides and just make sure that you have this information. The National Center on Health has a 24/7 info line, 888-227-5125, or email nchinfo@aap.org. And we encourage you to ask any health-related question. Any Head Start staff or parent can ask a health-related question, and we will be responsive. And if you need to reach me directly, that's my email as well, or you can reach me through Peggy and Eric at the association. Thank you, and I look forward to joining you on another call in the future, and I hope today was a helpful opportunity for you. Eric, you want to take it?
Sure, yeah, thank you, Steve. And I think right now we'll just, I know since we're over time, I think we should probably just go ahead and end. But if folks, have any follow-up questions, topics that they'd like to see covered in future webinars or anything like that, certainly email me or Peggy, and we'll make sure to get the next one scheduled, which will be December 8th at 10 o'clock. So everybody have a great rest of the week, and good luck getting all those all those requirements done. Have a great week.
Thank you.
Thank you.
Thanks for joining us, everybody.
Thanks.